Good morning, everyone. Welcome to second module, that is clinical examination in maxillofacial trauma patients. Now, first is the extraoral examination. Whenever trauma patient comes to you, complete inspection should be done. That is the for extraoral, that is a face should be washed with warm water and warm saline solutions. Cleaning of the any debris or blood clots. Check for presence of any edema, ecchymosis, deformity, and facial asymmetry. Bleeding areas, cerebrospinal fluid leakage, associated soft tissue injuries. For palpation of the fractures, palpation starts supraorbitally on either side of the nasal bridge, then frontozygomatic region, followed by zygomatic bones and zygomatic arch, then inferior orbital margin is palpated while standing in front of the patients. Examination for the mid-face fractures. We can examine various parts of the mid-face from the middle part to the dentoalveolar region for finding out the Leefort 1, 2, 3 fractures. For zygomatic fractures, you can check for the unilateral epistaxis, that is the bleeding from the nose. It can be unilateral or bilateral. Depressed malar prominence, that is the cheekbones are depressed. Or patient is having swelling around the eye, that is subcutaneous emphysema. We can feel a step in the infraorbital rim or altered pupillary level, periorbital ecchymosis. We can see redness in the eye area, that is subconjunctival hemorrhage, or we can feel ask the patient if there is any paresthesia around the infraorbital nerve distribution or eye is looking sunken in these type of cases. We can evaluate facial symmetry, that is a post-traumatic asymmetry we can check by various maneuvers. We can check for the scalp and skull, that is lacerations, contusions, or depressed fractures of the skull, that is a battle sign, that is near the mastoid process. We can see in this picture, there is the laceration in the scalp region and mastoids, that is ecchymosis near the mastoid process, that is the battle sign. Eyes, we can check the eyes of the patient for any debris, broken glass pieces, any lacerations, corneal abrasions, scleral tears, circumorbital ecchymosis, or circumorbital edema. Examine for the movement of the eye in all the gazes from upward, downward, and lateral movements and check for the potency of optic and oculomotor nerve. See this picture, we can see the circumorbital ecchymosis and redness in the eyes and laceration over the nasal area. We can check for the eyelid lacerations. It can be partial thickness or full thickness lacerations. Either canalicular system is involved or not involved. Then raccoon eyes, it's common for the Leefort 2 or 3 fractures. Nose, we can check for the nose, that nose is retruded or impacted at nasofrontal suture area with lack of support for nasal septal or cartilage fractures. We can easily check it by pressing over the nasal area. Subconjunctival hemorrhage, we can see the flame-shaped hemorrhage with posterior limit of which is not seen. Most commonly seen in the Leefort fractures or Zidemsey fractures, suspected fracture of the orbital walls. We can check for the pupillary reaction, whether they are performing normally or light response is normal or abnormal. We can check by closing patient's one of the eye. Illustration shows the optic nerve with impingement of the optic nerve at orbital apex. There is no indirect light reaction to the unaffected right eye. We can check for the laceration in the ear, that is laceration of auricle, external auditory canal, tympanic membrane. Check for any bleeding or foreign bodies point. If you see the whitish discharge, watery discharge from the ear area, that can be because of the cerebrospinal fluid leakage to the ear, that is otorrhea, CSF otorrhea. Check for any blood discharge, or this otorrhea is most commonly seen in case of dislocated condylar neck fracture or middle ear fracture. Examine for laceration or collapse of external canal. Examine for tympanic membrane for rupture or hemodympanum. Blood in ear canal may indicate that skull base fractures or external auditory canal lesion resulting from the condylar fractures. Make sure that the patient can hear with the both eyes. If both ears, if patient is not able to hear properly, that means there is damage to the some of the parts of the ear. Examine for hematoma of the auricular cartilage. If there is hematoma, it needs to be drained and through. Bolster dressing is recommended. This is to prevent any permanent deformity of cauliflower ear. In this picture, we can easily see a cauliflower ear deformity with possible compromise of external canal. Battle sign post-auricular bruising, bluish discoloration near the mastoid area posterior to the ear, or base of skull fracture it is commonly seen, or whenever condyle impacts above the middle cranial fossa and fracturing the mastoid process. Fronto-nasoethmoidal region, we can check for various fractures in these regions, involve the medial vertical buttresses of the facial skeleton. Nose, always check for the clinical examination of nose properly should be done. First to find out if there is any bleeding, that is unilateral, bilateral, or check for any watery discharge through the nose. That may be because of the leakage of cerebrospinal fluid from the nose area, that is CSF rhinorrhea. How we can diagnose this CSF rhinorrhea? Halo ring sign is seen, that we can see in this picture. Outside will be the whitish in color or yellowish in color. Middle portion will be seen as a red color. Tram lines are seen, and glucose, if we check it for the examination, glucose content will be more than 45 milligram per deciliter. Or we can say send it for examination, then beta 2 transferrin assay can be done for it. Tramline, deviation, asymmetry of nose. See in this picture, we can see there is asymmetry of the nose, deviated nasal septum is there. And leakage of CSF from nose due to what are the various fractures due to which CSF rhinorrhea occurs. That is mostly because of the cribriform plate of ethmoid plate bone is fractured, or Lefort 2-3 fractures, naso-orbito-ethmoidal fracture, or ethmoidal bone fracture. Patient complains of salty taste in throat post nasal leakage, or patient not able to blow nose vigorously. They should not blow their nose vigorously because there can be traumatic aerosol can occur, or increased intracranial pressure can occur. Traumatic telecanthus, nasal fracture, Lefort 3 fractures. These are the pathochromic for the naso-orbitoethmoidal fracture. Saddle nose, depressed nasal bridge due to the nasal bones. Traumatic telecanthus can be there. Mongoloid picture can be there, that is inclination of the palpebral fissure. That is fracture of the frontal process of maxilla to which the palpebral ligaments are attached. Normally the intercanthal distance is around 3 to 3.5 centimeter. See, we can see the saddle nose and anoid complex fracture is there, and intercanthal distance is increased. Now coming on to examination of the mandible. Inspect for any asymmetry or deviation of the mandible. In first picture, we can easily see there is asymmetry of the mandible and deviation of mandible towards the right side. Laceration, intraoral, extraoral laceration can be there. Condylar depression, condyle may be dislocated anterior to the articular eminence. The patient can have trismus or limited jaw movement can be there. We can palpate the symphysis, inferior border of the mandible, ramus of mandible, for any step deformity. Parade ground fracture, that is bilateral parasymphysis and bilateral subcondylar fractures are there. Most commonly occurs when patients falls on the ground while doing the parade. They will fall on the front side. They will have a fracture of the bilateral parasymphysis and condylar region. That is the second picture shows the Barton's bandage for the initial stabilization of the mandibular fracture. We can check for the areas of tenderness, step deformity, if there is any abnormal mobility, inferior border continuity, or angle of mandible fracture. See, in this picture, we can easily see the angle of mandible palpation and parasymphysis region palpation. TMJ palpation, we can check for the TMJ movements in the lateral as well as the anterior-posterior movement we can check. TMJ dislocation, patient can present with the open mouth. Open mouth patient cannot close their mouth or talk well, or may be misdiagnosed as psychiatric or dystonic erections. We can go for intraoral examination. That is the intraorally we can check for the any lacerations or hematoma formation in the various part. Intraorally may be the maxilla or mandible at particular fracture site. In this picture, we can easily see a laceration and fracture in the parasymphysis region of the mandible. See, palatal laceration can be there. That can be because of the simple laceration or some fracture in the palatal region. Palatal hematoma or palatal laceration can be noted in sagittally split palate. That is a part of Lefort 1 fracture or may be associated with Lefort 1, 2 or 3 fractures. In other internal examination, check for mouth opening, gagging of the occlusion, lacerations, ecchymosis. See, in first picture, we can see the laceration of the lip area and occlusion is disturbed. In second picture, we can see degloving laceration in the anterior part of the mandible. We can check for any blood clots or avulsed teeth, ecchymosis or hematoma, or we can check for the buccal sulcus and buttress region, or sublingual hematoma in case of parasymphysis fracture, or greater palatine foramen hematoma if there is fracture of the palatal region. Step defects in occlusion we can see, or gagging of occlusion we can see. In this picture, one of the famous cricketer, he is having fracture of the mandible while playing in the cricket ground. Anterior open bite or shift of the mandible in this photograph we can see. Bilateral, what is bucket handle fracture? It is commonly seen in case of edentulous patients. Bilateral parasymphysis where anterior segment is pulled lingually and downward by mylohyoid and digastric muscles respectively. So posterior segment is pulled backward, pulled vertically upward. So it will give a typical bucket handle fracture. Or intraorally, other examination we can do for the mobility of the maxilla and mandible. See, mobility of the maxilla which I can check by bimanual palpation. Radiographic examination. The following radiographic studies are helpful in the diagnosis of mandibular and maxillary fractures. For mandibular fracture, we can go for specific X-rays like OPG view, that is panoramic view, lateral oblique view, posterior anterior view, occlusal view, periapical view, reverse down view, CT scan. Even for the maxilla, we can go for the various X-rays like OPG view, CT scans, 3D CT scan is also available. We will conclude that a thorough clinical examination is required for definitive diagnosis. Thank you.